Okay, my name is Margarida. I'm a second-year PhD student in VCMI and in ProDep, in the doctoral program in biomedical engineering. I work under supervision of Professor Tanya and Professor Elwood. So Tiago asked me to talk about my PhD. So basically, I will present some part of what I did in my defense of my thesis plan, and also present part of the preliminary work that I developed after that. So starting by the name of my thesis plan and my PhD topic for now is generalizing learning models for out-of-domain medical images. So starting by a brief context and motivation. As you know, deep learning is used to process any kind of medical imaging nowadays, and we use deep learning to process different types of medical images and for different tasks that goes from classification to segmentation, detection, and also registrations. And we use these methods for different type of images. Some of them are 2D, some of them are 3D. Some of them, like ultrasound, are kind of a video, so they have different characteristics, but deep learning already show potential in dealing with different kind of images and different tasks. But as you may know, since most of you may work with medical images, working with medical images has several challenges and limitations, especially data related. So normally we have small data sets have bias, are unbalanced, and for some data sets we have a lack of annotation, and sometimes even when we have annotations, these annotations have noise and also have low quality. So these factors combined affects the generalization of the models. So the main objectives of my thesis is to address two main problems of lack of generalization. So the first and more typical one is the lack of generalization between cohort populations. So populations that show different demographics, different anatomical pathologic characteristics, and normally are represented in different data sets. So a data set is acquired in an hospital and will represent the population of that area of the hospital. In addition, when the images are acquired in different hospitals, sometimes the process of acquisition follows different imaging acquisition protocols, different scanners, different vendors, and on top of that, we also have different annotation protocols for different data sets. The second problem not that common, but that still happens, is the lack of generalization between distinct image modalities. So sometimes we have a clinical protocol that indicates that a pathology should be evaluated in a type of medical image, for example, a CT scan. But sometimes if the patient, for other reason in the past, has done an MRI scan, the physician can use this scan and use the scan to evaluate the patient without the need of doing a different scan. But when we work with models, normally they are only suited to deal with one type of medical image. And even, for example, inside the MRI scan is only suited to deal with one sequence of the MRI scans. So this is the second problem. So first, I will just present some concepts about out-of-domain generalization, a very small overview, and then I will present some of the analysis of the literature, high level, but just to give you an idea. So as you know, the main shifts can cause a decrease in performance from the source to the target domain. We can easily consider like the source domain, the training domain, so domain where we train our models, and the target domain we can consider like the test domain, or in a real scenario, the deployment setting. To address these kind of problems, we have two strategies that I think you may know. So domain adaptation, when we have access to the target domain, this access can be in the form of label and unlabeled data. So we know that the model will be You want our model to be employed in a different hospital, and we can go to that hospital and acquire some images that can be annotated or not, but we can analyze the images and understand the target domain. When we cannot access the target domain, so we can look to the problem as a domain generalization problem. So we simply know that in the future, we'll have different hospitals where we want to apply our models, but we don't have access to data from that hospital. But we still want that our model to behave well with that kind of images. So these problems are different, but regarding the literature analysis, you can see that the methodology to address the problems is very similar, because, for example, if we have access to target domain, we cannot ignore that access that don't consider, and the problem becomes a domain generalization problem. And even when we have access to the target domain, the methods are very similar to domain generalization, and I will try to present the methods. So let me just in the simpler type of, I use the division and categorization of methods from literature reviews. So you probably can divide this type of methods in different categories, but I follow the ones that I found in the literature. So starting by methods that are based on data manipulation, that are probably the simpler ones. We have, of course, data augmentation. I think all of us use the data augmentation at work. And as you know, we can perform transformation to the images, rotations, changes of contrast, things that transformations that are simpler, but at the same time can result in unrealistic images. For example, if we change too much the contrast of an image, the image can become unrealistic. And at the same time, the set of transformations that we can apply is small, so that augmentation has the limitations. So besides the typical and general transformation of images, of course, for specific problems, we can try to employ the domain knowledge of the problem to manipulate the images. So this is an example of the work of Joanna. She's laughing because this is a work of her. Basically, she was trying to promote generalization of segmentation of the lungs, and what she did was artificially incorporating lung nodules to try to mimic lungs with nodules. So, but this type of transformations have potential, but at the same time are hard to optimize and are limited to the access and the domain knowledge of the problem. And of course, we also can use a differential data augmentation. We can use a differential learning to manipulate images. But as you know, adversarial learning has problems with optimization. So passing to the second part, we can also use adversarial learning or GANs or diffusion models to generate synthetic data that we can use in training. This has also some problems, especially when we are talking about medical image, because probably only physicians or persons with clinical background can look to an image and say if the image is realistic or not. We can incorporate images that we don't know if they are realistic in training, but by principle, we want realistic images. So this is dependent of clinical validation. We can also, instead of doing data augmentation, we can work at the level of the features and perform feature augmentation. Problem of this type of method is that sometimes when we are manipulating features, we can create new samples, but we don't know. Sometimes cannot do this step back and understand how that set of features is in this image space, and we can be creating unrealistic samples. So passing to methods that are based in learning process of the models. So we have methods based on representation learning, where we can use the differential learning to promote learning of invariant features. So basically, we have a model that tries to discriminate different domains, and that provokes that the features are invariant to changes in domain. Once again, adversarial learning, problems of optimization. Some works focus on domain generalization also use multitask learning. The idea is that if we are learning features that are shared between different tasks, these features are more meaningful for the problem, and with that are less sensible to domain changes. Debatable, but we can also, instead of promoting the learning of invariant features, we can try to separate the features that are domain specific and domain not sensible to domain changes with entangled representation learning. And of course, you can use model regularization. And with model regularization, it's a way that we can incorporate domain knowledge in the problem. And sometimes we can provoke domain generalization with this. So different type of methods also that I didn't explore much on the literature of my literature analysis, but of course you can use in several learning, combine different models, try to have a better model. In the end, if the model is better, probably generalize better. Of course, you can use self-supervised learning for pre-training models, take advantage of large amount of data that are not annotated. Of course, for example, for domain adaptation, a simple approach is training a model in the source domain, take a few samples of the target domain, use transfer learning and fine-tuning the model to the target domain. So, but this only can be done for domain adaptation, domain generalization. If we don't have access to the target domain, we cannot do this. And meta-learning, I didn't explore much, but this is something more recent that starts appears in the literature for promoting generalization. But the feedback from the literature that I had is also we need different target domains, different source domains to train the models. So that is also challenging. So now looking at literature, I will just characterize a little bit more the problems that I will address or try to address in my thesis. So basically for each of the objectives, we identify a real use case connected with projects of the group to try to have a real impact. So for generalization of core population, as you know, the group works a lot with lung cancer. So, and is a use case where we already have some documentation of the lack of generalization. So we train models in one data set, we apply the models to a different data set, the performance decay. So the first use case is based on classifying lung nodules. We are working with this case like in we don't use just one source domain, we try to use multiple source domains and combine them to promote generalization on the target domain. So just a small overview. Most of you work with lung cancer probably, but so lung cancer is the most deadly type of cancer, but the survival rates increase with an early diagnosis. The problem is that people, when they have symptoms of lung cancer, the cancer is already in an advanced stage. So we start having screening programs. For example, we have in the United States, we have data sets from screening programs, but now, for example, in the European Union, they are working in a screening program to the European level to try to detect early type of cancers. So in this screening, normally the images required are CT scans. In the CT scan, the physician can identify a lung nodule, assess the risk, and if the physician thinks that the nodule has a high risk of lung cancer, the patient is subject to a biopsy, and the biopsy will confirm or not if the lung nodule is malignant. So we can have CAD systems that can help in both detection and the classification of the risk of malignancy. I work mostly with the classification task. So looking at the classification task, the state of the art is mainly based on CNNs. They are used for feature structure or in the end-to-end classification, and they reach high performance. But looking at the literature, what we can find is that most of the works are based on a single data set. Data set is the LEDC data set, and this data set has a few problems, especially regarding the annotations, because ideally we want the biopsy result of the nodule. So we want real confirmation if the nodule is cancer or not. But for this data set that is most used and probably the biggest one publicly available, we have an assessment of the likelihood of the malignancy. So physicians open the CT scan, look to the nodule, and gave a grade from 1 to 5 if they think nodule have a high risk of malignancy or a low risk of malignancy. And several radiologists annotate the same nodule. Just for that, we can see a high variability on annotations. So we have cases where a radiologist gives a grade of 5 to a nodule and the other gives a grade of 1. So just for that, you can see that labels are not that certain. We have, for this data set, the models achieve outcomes above 0.95. Looking to this, we could say that the problem is solved. But we have a few number of works in the literature that apply the models to a different data set or that are even trained in a different data set. And for these works, the performance is not close to 0.95. So clearly we have a problem of lack of generalization. And in this problem, we have different factors that can cause the domain shift. So images, once again, images acquired in different hospitals, different protocols, different screening populations, and also, of course, different protocols for annotation of the data. I will talk in the second part of my presentation a little more about this use case because my preliminary work was with this use case. So when I present the results, I will explore this a little bit more, but just to present the second use case. Basically, the second use case is the detection of bone marrow edema in the knee articulation. So basically, it's the accumulation of liquid in the knee. Normally, the standard of care is using MRI scans to evaluate this liquid accumulation, but what the physician wants is like a continual process of monitoring the evolution of the disease. So MRI scans are expensive. The ideal idea is to do this detection with X-rays, but this is the goal. Like, I don't know if that is possible, but at least we want to try to use different MRI sequences and try to promote generalization between them. So I think I already see this. So looking at the problem, as I said, normally MRI scans, looking at the literature is not a problem that is so explored as the classification of bone nodule, but a few works for detection already exist. They are normally based on a single medical modality, MRI scans, and inside this type of imaging modality, the models are only prepared to work with one of the sequences of the MRI scans. But the problem is approached in different ways. Some works do detection, so like bounding boxes, try to identify the region of the edema. Some transform the detection problem in a segmentation problem, and others basically do patch classification, so dividing the images in patches and try to classify each patch to the presence or not of the disease, and with this detect the disease in the complete images. So as I said, the problem shows a lack of generalization between different imaging modalities. So the models are only suited to deal with one of the MRI sequences. So passing to the preliminary work, sorry, I'm drinking water. So, my preliminary work for my thesis research plan, and then the work that I continued to develop last semester basically was based on classification of lung nodules. So I think I can skip this introduction, basically data about lung cancer in the presentation problem. So the idea is that we know that these types of models, deep learning models, when applied to lung nodule classification, have a lack of generalization. So our goal was like establish a baseline model, evaluate the performance of the model in external data sets, try to quantify this decaying performance, and try to implement the simple approach to deal with this, that is data augmentation. But sometimes what also we did with our work is try to compare the performance of our models with radiologists, and also try to understand if we can identify some characteristics of the images that we can associate to this domain shift problem. So this idea came from my research. Basically, for example, for chest X-rays, we can find a lot of works that try to associate parameters of the image acquisition protocols to different performance of the model. So we can say if the images were acquired with this set of parameters, the performance of the model will be high, will be low. I tried to do some kind of analysis similar to this for this problem, but I will show the results next slide. Basically, I used 3 data sets, the LVC, this is the bigger one, public. Basically, for this, as I said before, we have 5 levels. We did what is normally done in the literature. So level 1 and 2 is considered non-cancer, level 4 and 5 is considered cancers, and cases with level 3, so ambiguous, are discarded. The LNDB dataset is a dataset from Inesptec, from the CBER group, was acquired for a competition. It's public, it's a small dataset, but the annotation process was they followed the same protocol as the LADC, so it's a different dataset, but considering the type of annotation is in domain data. And then a small dataset, LongX dataset, it was also acquired for a competition, but for this dataset, we have access to the results of biopsy. So we have confirmation for if each nodal is cancer or not. So basically, the LEDC was our main data set for training, and then we evaluate models in the 2 data sets. And for the second part of the work, we also use the LNDB for training, but I will explain this next. So for processing, AGAU normalization. I don't know if you all know what AGAU is, but basically each pixel of a CT scan is resulted of all the X-rays were attenuated by the type of tissue that we have in our body. Each value has a meaning in the scale of AGAUs. For example, we can associate the AGAU value with a type of tissue, or with water, with hair. Sorry. So we did the normal normalization when we want to analyze lengths. That is from normalized to 0 and 1, sorry. And resample, sorry, I was missing concepts. And resample is basically, we have parameters that each voxel of the images is translated to a volume of our body. That is this parameter is controlled during acquisition. So sometimes we have a high number of slices of CT scan, sometimes a low number. So we use interpolation to try to transform our data to have homogeneous parameters. So we do interpolation to isotropic voxels. So what we tried when we established the baseline was trying the more simple approach, the 2D approach. So basically, for each nodal, we just consider a slice and a box, a 2D box. We also consider the 3D volume, and we also tried to use something that we call 2.5D, that is basically trying to extract the anatomic plans of the nodule and combine them in the input of the network. So we can use 2D networks, but at the same time, trying to give to the model special information about the nodule. And since the data set is imbalanced, we use just oversample the minority class to balance that set to train. So data augmentation, this was based on work that proposed BGAU, but BGAU is basically the normal transformation that we do to images. The idea of this work is that the ranges of parameters are adjusted to medical images. So if we are changing, for example, the contrast of the images, we will not change the contrast. Don't pass the limits of a realistic medical image. So basically, we apply these transformations. They are like all applied. We apply all with a probability of 0.5. So we can apply 9 transformations at the same time, or it depends on the probability, but sometimes we apply 1, 2, or the 9. But basically, these are transformations. So model, we use a resonate, binary cross entropy for the loss function, optimizable stochastic written descent, a set of hyperparameters. So trying to pass to the more interesting part, I think. So basically, the first experiment was just trying to understand what kind of inputs is best for our model. So we train our model in the LEDC data set. We have a small set of the LEDC that we keep as internal test set. We use the other 2 data sets as external test sets. So I was trying to use the laser pointer, but I don't know if it's working. So a lot of numbers, but basically looking at the results for the internal test set of the LEDC, the 2.D models and 2.5D models have similar houses. I forgot, I did cross validations, and because of that, we have the standard deviation. But they have similar houses. The 2.5D model presents a slightly higher balance accuracy. So we consider this our best model. For the 3D, the performance was low. What was low in comparison with the other models, of course, was what was kind of unexpected, because according to the literature, 3D is best. But probably our model didn't have enough time to optimize, and the loss didn't. Since the models are more complex, they probably should be trained for more epochs, but this was limited time for experiments, so these are results. The results are good, but still don't reach the performances above 0.9 of Alcia. That was our reference for the LEDC. So second experiment was trying to use the data augmentation. So we considered the 2.5D models and basically use the same training settings. We only change use, well, start using data augmentation. So what we did was trying 2 different levels of data augmentation. So the first, the baseline from the previous no data augmentation, the 2 levels is basically we apply data augmentation to the image, but we don't try to augment the number of samples that our model sees. And we try the second level of data augmentation was try to double the number of samples that our model sees during training. So in the internal test set that I will talk next about the external ones, but for internal one, the impact was very low. But we improved the results, but to values above 0.9, but not yet close to 0.95. That's something that happens, especially when we use models that incorporate to my knowledge for model classification. So models that are not net simple. So passing, looking to the external data set, starting by the data set that has annotations similar to the training domain, we can see that data augmentation improved the results. The higher level of data augmentation, the best results are for applying data augmentation without doubling the training data. The performance is still below the state of the art. This dataset is not the most used one, but we have a few references of the literature made, especially the works of Siever that worked with other dataset. And in their work, they achieve higher performance in the dataset. Our difference in comparison with their work is that they also use the LEDC for training, is that our performance in the internal test set is higher in comparison with theirs. but they achieve a higher performance in this data set. Their model is not just suited to predict the lung nodule malignancy. They use basically multitask learning to predict other attributes of the nodule. So it's not directly compared to ours, but it's the reference that we have. So looking to the LungX dataset, that is probably the most challenging dataset, as you can see for us from our starting point, like performance slightly above 0.5. We can see that we can achieve the higher performance when we double the training data. As I said before, the annotation of these data are different from the training domain, but with our models, we reach performances above the performance that are presented in the challenge report. And in this challenge report, basically paper, they explain the models that were submitted to the competition, but they also present the performance of radiologists that evaluated the lung nodules. So it's just visual inspection and compare that with Rancho labels. And as you can see, like the performance of radiologists is not like above 0.9. So even when radiologists are analyzing the images, they miss a lot. Our performance is still low when we compare with the work that exists in the literature, but this work uses an LSC dataset. This dataset has the biopsy, so basically they train with data that has the same type of annotations. That was not our case. So just I tried to analyze the more different of annotations. And first, reduce number of nodules of the LEDC, like 28 nodules, something like that. We have like the biopsy result. And if you look for just an analysis of nodules that are malignant in the mean, so this is about the biopsy, but we can see the likelihood of malignancy, and we can see that like the radiologist failed a lot. I don't have results yet, but I was trying to use our models to compare our performance instead of using as a ground truth likelihood of malignancy, try to use this and calculate performances. I don't have yet its results, but I will do this analysis in the future. So this experiment was just a starting point, so I can give you just a small insight of the conclusions. So I didn't have time to analyze this deep, so lots of numbers. But basically what I did was the dataset from CBER, the images were acquired all in the same manufacturer, the same acquisition protocol. In LADC, we have images from that follow different acquisition protocols, different manufacturers, different process for reconstruction. So what I did was turning out my model in the dataset from CBER that is smaller. So we of course don't achieve the performance that we achieve in LADC, but with this we can have a model that was trained with images that have a homogeneous and acquisition protocol. What I did was try to evaluate my model in the LDC, trying to group subgroups according to acquisition parameters, try to understand if I can identify parameters that affects directly the domain shift. Just some small conclusions. What I saw was that, for example, the manufacturer, the performance for different manufacturers is similar, but analyzing this, you need to consider that the number of samples that I have for different manufacturers is different. So just a starting point. The other factor that I also analyze is the reconstructed convolution kernel. Basically, when the images are acquired, according with the type of the body region that the physician wants to analyze, the images has in the machine in the process of reconstruction as some kind of pre-processing that can highlight some regions, and some of this pre-processing is more suited to analyze the lung area. Some are more suited to if you want to analyze bones. Some is just a standard protocol if you don't know yet what you want to see in the image. So it seems that the LEDC had different parameters. What I tried to was try to group these images according to parameters. And what I saw, so I forgot one thing. Different manufacturers have different names for this parameter. So Daniela knows a lot, she tried to help me with this. And we don't have a lot of documentation where they explain what is the most suited parameter for you if you want to analyze lungs. So the best manufacturer is basically a medical system where the name of the parameters explain clearly what their goals. So looking to bone, lungs, and the standard protocol. So basically, considering this, we saw that images, so nodules that come from images that were acquired with LURC convolutional kernel. In these nodules, our model behaves best. And basically, this filter, what it does is apply like an edge enhancer filter that increases the contrast for the lung area. So in second, we have the standard protocol and then the both. Other analysis that I did was for the Siemens, since the Siemens was the manufacturer from the dataset from Sieber that I use in training, and they use fast convolution kernels that is in the Sieber. So what I also saw is that the images from that has the same convolutional kernel as the training dataset, the performance is higher. But this is just preliminary results. Conclusions. So our 2.5D models were the best ones. Basically, the models, this type of input combines two things. We can use 2D models that are for simple optimization, but at the same time, we can give special information to the models. Of course, training in the source domain and evaluating the target domain that reduces the model performance. The data augmentation reduces the domain shift, especially when you are evaluating the external data sets. Yeah, the performance was close to the state of the art when we evaluating our models in data sets that have like true malignancy of the nodules, the performance decays. And the last conclusion still in analysis is that some CT acquisition parameters can impact performance, but we still need stronger strategies to promote domain generalization. Yeah, I can pass this part.